Good morning, good afternoon, and good evening to everyone who's joining us today. We're just waiting for everybody to start trickling in a little bit. And while we wait, let's go through some housekeeping issues so that everybody is comfortable using the Zoom platform. I'm sure we've all used it before, but just in case, we have just a few reminders. So I'd like to welcome everyone to World Breastfeeding Week of 2026. Today's webinar is Strengthening What Works, where we will share new evidence to accelerate investment in breastfeeding. And it's brought to you by the World Health Organization and UNICEF in partnership with the Global Breastfeeding Collective. I'm Dr. Nina Chad, infant and young child feeding consultant with the World Health Organization, and I am pleased to serve as your moderator today. Before we begin, let's have a look at housekeeping. We're offering the webinar today in Arabic, Chinese, English, French and Russian. So if you need to access interpretation, please click on the interpretation icon in your toolbar, and that's shown in the slide here. Click the interpretation icon and then select your preferred language. Closed captioning in English is available for delegates using the Zoom app on a computer. And to view those live captions, please click on the CC icon and select Show Subtitle. To ask a question, please click on the Q&A icon. Q&A will be open from right now. You can post your questions there and direct your question to a specific speaker if you would like. Panellists may respond in writing in the Q&A box, or your question may be addressed during the live Q&A segment later in the program. Please note that the webinar is being recorded, so if you have someone you'd like to share it with, that will be possible. I'm going to begin by sharing today's agenda. We'll start with opening remarks, followed by a video featuring the voices of mothers, because after all, that's why we're here. From there, we'll set the stage with the Global Breastfeeding Scorecard, hear what evidence shows works, and work through the findings of the updated global investment case. From there, we'll turn to a donor perspective, followed by country-level perspectives from Kenya, Pakistan, and Tanzania. We'll close with a call to action, and hopefully we'll have some time to answer your questions. It's now my pleasure to introduce Dr. Joan Matchie, UNICEF's Global Director of Child Nutrition and Development. Joan brings opening remarks on behalf of UNICEF and WHO, and Dr. Matchie has more than 20 years of experience in public health nutrition. She's previously served as UNICEF's Regional Nutrition Advisor for Eastern and Southern Africa. Her full biography is available in the chat. Over to you, Dr. Matchie.
Thank you so much, Nina, for that kind introduction. Good morning, everybody. Good afternoon and good evening to all of you who are joining this important session today. I send you warm greetings from the UNICEF Center of Excellence on Child Survival and Development in Nairobi. It is my pleasure to welcome you all today. This year's theme, Strengthening What Works, New Evidence to Accelerate Investment in Breastfeeding, reminds us of a simple but important reality. Breastfeeding is one of the most powerful investments we can make in child survival, growth, and development. Yet, with all this knowledge we know that for mothers to successfully breastfeed, they need supportive health systems, enabling policies, family-friendly workspaces, and strong communities. Building these systems carries a cost to governments. However, the returns are exceptional. Every $1 invested in breastfeeding can generate up to $59 in economic benefits. At a time of constrained resources, rising commercial pressures, and growing nutrition challenges across the world, this gives governments a compelling reason to prioritize and scale up breastfeeding support. Ladies and gentlemen, colleagues, globally, we have made progress. Today, 47% of infants under 6 months are exclusively breastfed. Yet, we remain short of the World Health Assembly target of 60% by 2030. Reaching that goal will require stronger policies, increased financing, and sustained commitment. As we launch the updated global investment case for breastfeeding today, the encouraging message is clear. We already know what works. Proven interventions such as breastfeeding counseling, baby-friendly hospitals, implementation of the International Code of Marketing of Breast Milk Substitutes, community support programs, maternity protection, and family-friendly workplace policies all contribute to significantly improve breastfeeding outcomes when delivered at scale. The new evidence that will be shared today goes even further. It shows a gradient of progressively larger investment packages, delivers correspondingly greater impact and economic return. In short, the more we invest, the more we gain. Today, we will hear the findings of the new investment case for breastfeeding, which will provide governments and partners with a powerful tool to advocate for increased investment in one of the highest return interventions for child health and human capital. We will also learn from country experiences that show how evidence, commitment, and investment can drive progress at scale. UNICEF and WHO remain committed to working with governments, donors, civil society, health professionals, and communities to protect, promote, and support breastfeeding. Together, we know we can translate evidence into action and investment into impact for children across the world. As we begin, I encourage you all to think about how the evidence presented today can strengthen advocacy, inform policy, and unlock greater investment in breastfeeding. The case for action is very clear. The benefits are substantial, and the cost of underinvestment is simply too high for children, families, health systems, and economies. Thank you for joining us today, and I wish you a productive and inspiring session. Back to you, Nina.
Thank you so much, Dr. Joan, for that powerful reminder that we already know what works and that investing in breastfeeding returns as much as $59 for every dollar spent. Let's hear directly from the mothers themselves who are likely to benefit from such an investment. This short video will remind us of the people we are here for today. Thanks, Kelly.
J'ai réussi à allaiter grâce avec toute l'équipe qui était formée et qui répondait à mes demandes, à mes sollicitations jour et nuit avec beaucoup de bienveillance.
Mình đã cho con trai Ti được 39 tháng rồi, bởi vì mình đã cho con Ti được ngay từ những ngày đầu tiên sau khi sinh, cho nên hành trình cho con Ti mẹ thực sự là rất đơn giản. Mình mong rằng là tất cả các nhân viên y tế đều có kiến thức đúng về sữa mẹ để có thể hỗ trợ những người mẹ có khẩu cho con Ti đúng ngay từ những ngày đầu tiên.
When I had some difficulties, they said, "You'll do that, don't worry, we will do that."
كنت أعاني من قلة إضراب الحليب، ومع أخصائية الرضاعة أعطتني بعض الإرشادات والتوجيهات من ضمنها خطوات فعالة لزيادة إضراب الحليب.
The pediatric doctor came to assure me about my preterm baby's 26 weeks, and she told me she just need 1 ml from the colostrum. Since that time, my baby completed her breastfeeding journey for 2 years.
The help I wish I had from healthcare providers is advice on the breastfeeding, physically showing me how to do it.
32 ngành dược sĩ, đa số những dược sĩ cùng nghề với mình chưa được cập nhật những kiến thức đúng về sữa mẹ.
Unfortunately, I had a lot of misinformation that confused me.
임만실에서 간호사 선생님이 제게 이거 수유를 하면 아가 체중이 줄 텐데 괜찮나요? 라고 물으시길래 제가 무척 혼란스러웠던 기억이 있습니다.
Los pediatras me dieron una información errada y me dijeron que debía darle de lactar a mi bebé cada 3 horas.
이게 태어나고 완전 모유 수유
콜을 희망한다고 했었는데도 굳이 3시간 아니면 새벽에는 콜 없이 그 분유로 수유했던 게
I had lovely nurses that sat with me, helped me to breastfeed, encouraged me.
ولدت ولادة قيصرية، أعطوني إياها ورضعتها رضاعة طبيعية. بالنسبة لأنها هي preterm النيرس علمتني أحتسب الحليب.
Cảm ơn nhân viên y tế được hướng dẫn tự bú đầu tiên và được hướng dẫn về ý nghĩa của sữa mẹ.
ባለሙያዎች አሁን አገልግሎት የማገኘው 10 እስከ 12 ጊዜ በቀን መጥባት አለበት ልጁ ሌሊትን ጨምሮ ማለት ነው።
Na zo asibiti awo ma'aikatan lafiya suka bani shawara. Yaro na ya tashi da kuzarin jikin shi kuma ba cututtuka.
وجوزني طياه ويا من صرت بريزة الدكتور وكمانيتي.
ولله الحمد من قبل ومن بعد تمكنت من إرضاع. أرشدتني إلى أهمية الرضاعة الطبيعية وكيفية مص الطفل للحلمة.
Toàn trực tiếp ở nhờ sự hỗ trợ của đội ngũ tư vấn viên sữa mẹ mình đã vô cùng biết ơn tất cả mọi người.
Agradezco mucho todo eso y valoro mucho.
That just made all the difference with all 3 of my babies.
កូនដោយទឹកដោះផងដែរខ្ញុំសង្ឃឹមថាបងប្អូនស្ត្រីគ្រប់រូបនឹងទទួលសេវាកម្មនៅមន្ទីរពេទ្យ
da shawarar da ma'aikatan lafiya suka bani saka da muna godewa Allah ya ci gaba da muna godiya sosai akan shawarwarin da suke ba mu Allah ya saka da alheri.
والحمد لله زادت نسبة إدرار الحليب لدي. شاكرة قسم الرضاعة الطبيعية على مساعدتها وفي الاستمرار على
Gracias por todos los retos que pudimos superar juntas.
Nhưng chúng tôi không thể làm điều này một mình.
Thank you so much to the mothers who shared their experiences with us for that video. Their voices are why we are here today. And thank you also to the partners who helped us to coordinate the collection of those videos. It is a very powerful story, a very powerful reminder of what's important and why we're here. It's now my absolute pleasure to introduce Ms. Fatima Sase, who's the nutritional specialist for infant feeding at UNICEF headquarters in New York. And she will set the stage with the Global Breastfeeding Scorecard. Fatmata manages the infant feeding portfolio at UNICEF and has 18 years of experience in maternal, infant and young child nutrition in both development and humanitarian settings. Over to you, Fatmata.
Thank you so much, Nina, for that beautiful introduction. Colleagues and everyone joining us today, we've just heard directly from the mothers about their breastfeeding experiences. And the Global Breastfeeding Scorecard really allows us to step back and look at these experiences at a global level. It really helps us understand where progress is being made and where additional support is still needed. Next, please. As we can see here, the Global Breastfeeding Collective, led by UNICEF and WHO, identified 7 priority actions. And these range from maternity protection to stronger implementation of the code, breastfeeding counseling and support services, community programs, as well as better data systems. The scorecard is really built around the collective 7 priorities together with countries' breastfeeding practices. Next slide, please. The scorecard has been published annually since 2017, and it now covers 194 countries. It combines data on breastfeeding practices with information on policy and program implementation to really allow us to track progress towards the 2030 targets set by the collective. And importantly, it really helps us to understand not only whether breastfeeding rates are improving, but also how and what is contributing to that progress. Next slide, please. So today, I'd like to highlight some of the key findings from the 2025 Global Breastfeeding Scorecard. We can see here, over the past 5 years, continued breastfeeding at 1 year has increased from 67 to 76%, while continued breastfeeding at 2 years has risen from 38 to 58%. This is particularly encouraging because continued breastfeeding receives less attention compared to exclusive breastfeeding. But yet, this is the period most heavily targeted by aggressive follow-up and of marketing, which is really problematic during this period. But the good news is women, mothers, still continue to breastfeed during this period. And as we can also see here, exclusive breastfeeding rates are moving at the right direction. Today, 47% of infants under 6 months are exclusively breastfed globally. This represents meaningful progress, but we are still short of the 2030 target of 60%. And also, one area where progress has stalled is early initiation of breastfeeding, with only 48% of newborns that are breastfed within the first hour of life, which is well below the 70% target of the collective. Given that more women than ever are delivering with skilled healthcare personnel present, this really remains a major opportunity for improvement moving forward. Next slide, please. This slide really shows what is possible and what countries can do and are able to demonstrate with support. We can see here between 2015 to 2019 and between 2020 to 2024, 15 countries increased exclusive breastfeeding rates by at least 5 percentage points in just 5 years. And these countries started from very different places. Some were already performing well, while others started from a much lower baseline. While there is no single recipe for success, as we all know, these countries demonstrate that meaningful progress is possible when breastfeeding is prioritized. And that momentum is continuing, and we continue to see that. At last year's Nutrition for Growth Summit, we saw that 24 countries made commitment to strengthen breastfeeding support in their countries. Next slide, please. But the obvious question is, what drives progress? We know that breastfeeding outcomes do not improve on their own. They improve when mothers and families are supported by the right policies, the right programs, and the right investment. This is why the collective really established the 7 policy asks as well as indicators and set this ambitious target that, of course, achievable if we can do more by 2030. These indicators that we can see here really allow us to assess whether countries are putting in place systems needed to protect, promote, and support breastfeeding. The outcomes we have just discussed are therefore not only part of the story. To sustain progress, we also need to understand the policy environment behind these results. Next slide, please. But of course, measuring progress we know requires reliable data, and the scorecard draws from multiple global sources. From implementation of the code, we use the latest code status report together with UNICEF internal Nutri-Dash reporting system. For maternity protection, we rely on data from ILO. Then for information on breastfeeding counseling, this is also drawn from Nutri-Dash, while broader policy and program data usually come from World Breastfeeding Trends Initiative, which we all know is coordinated by IBFAN in collaboration with BPNI as well. Together, we know that these sources provide a comprehensive picture of whether countries are putting in place the programs, the policies, and systems that are needed to support breastfeeding at scale. Next slide, please. So what do the policy data tell us about where we are and how we're making, where we're heading to in terms of progress? As we can see, the policy data reveals both progress and significant gaps. On the financing side, only 4% of countries currently receive at least $5 per live birth in donor funding for breastfeeding, compared with a 25% target for this indicator. And on maternity protection, only 1 in 5 countries guarantees both paid nursing breaks and breastfeeding facilities in the workplace, and only 1 in 10 meets national standards for maternity leave. But on a positive note, we are seeing progress moving in the right direction for code implementation. And as of 2025, we saw that 33 countries had measures substantially aligned with the code, and this has even increased further to 37 in 2026. So the overall message is very clear that stronger policies remain essential if breastfeeding rates are to continue improving. Next slide, please. On the funding side, this deserves particular attention. We can see from the slide that the greatest financing needs are concentrated in low and middle income countries. And yet these are frequently the countries that are facing the largest financing gaps. This really highlights the importance of increasing domestic funding alongside continued donor support for breastfeeding programs where needed, because without adequate financing, even the most effective policies and programs cannot achieve their full potential. Next slide, please. There are also some encouraging signs and progress that we can see here. In this slide, it shows that 3/4 of countries with community-based nutrition programs now provide breastfeeding counseling in most districts. This growing support network is likely contributing to the gains that we are seeing, particularly in the continued breastfeeding rates. But at the same time, monitoring remains a challenge, with only 40% of countries have collected data on exclusive breastfeeding within the last 5 years, and funding for data collection continue to decline, as we all know. But better data really helps us understand what is working, where gaps remain, and where investment can achieve the greatest impact. Next slide, please. So before I close, I want to leave you with 3 messages. First, to say progress is possible, and we are seeing it happening across very different contexts. And secondly, countries making the greatest gains are investing in policies and programs that support mothers and their families. And then thirdly, important gaps still remain, particularly in financing, maternity protection, and implementation of the code and data systems. The challenge now is accelerating and sustaining the progress, as well as increasing the momentum to match the progress that we are making in improving breastfeeding outcomes. So with that, I will hand over to Nina. Thank you.
Thank you, Ms. Fatmata, for that overview on the country level progress for protecting and supporting breastfeeding. And also for reminding us that although the recipe for improving breastfeeding outcomes will be different for every country, the ingredients are always the same because we know what works. And for more on that, I'm pleased to introduce Dr. Lawrence Grummer-Strawn, or Larry, as we all know him, as many of us know him, the unit head for the Food and Nutrition Actions in Health Systems unit at the World Health Organization. Larry's going to walk us through what evidence shows works. Larry previously served as the chief of the nutrition branch at the United States Centers for Disease Control and Prevention, and he's published more than 180 scientific and peer-reviewed papers. Over to you, Larry.
Thank you, Nina. And good morning, good afternoon, everyone. Glad to have you with us for this World Breastfeeding Week focus on strengthening what works. Go to the next slide, please. As we look at what works, we really have to look at what is the evidence. We want to make sure that we're not just saying this is our priority, as everybody should do this because we say it. We need to really look to the literature. And for that, we have to look not just at single papers, but look at systematic reviews. And so that's what I want to present today, is what does the evidence show about these key interventions that Fatmata was just describing as our priorities moving forward. As we look at what works and how well it works based on the evidence, we've broken this down into 3 different chunks of kinds of interventions. First, we start with health system support. We know that is the basic of what all women need for breastfeeding. They have to be supported. And I think that the Voices of Mothers video that we saw earlier really illustrated how much mothers value that kind of support. And so we look here at both skilled counseling and education in health facilities and community settings, as well as the 10 steps to successful breastfeeding in that health system support. And then we look at what do we get by adding to that communications interventions in terms of mass media promotion and enforcement of the Code of Marketing of Breast Milk Substitutes. And then finally, we're going to look at employment support in terms of paid maternity leave and workplace breastfeeding policies, because we have found evidence that all of these are effective in supporting and protecting breastfeeding. Next slide, please. So let's start with breastfeeding counseling and education. This has been called for a long time. The Global Strategy on Infant and Young Child Feeding from about 20 years ago has called for skilled counseling to be provided at basically every opportunity that we have with mothers and babies. And it listed out a variety of different places where this can be provided. It was basically on an as-needed basis, but that we need to take advantage of the opportunities that we have to provide that kind of care. WHO a few years ago did a much deeper dive at the evidence around this to find what exactly do we recommend for counseling women to improve breastfeeding practices, and came up with a series of recommendations, but it really boiled down to that every mother needs to have a minimum of 6 breastfeeding counseling contacts, including during pregnancy as well as throughout the first 2 years of life. And this was in some ways a sea change in the way we think about counseling. Up until that recommendation, it was kind of an as-needed basis. Make sure that counseling services are available for those mothers who have difficulties, who are asking questions, who are having problems. And that's really trying to change this around to say, no, healthcare systems need to be prepared to provide that support for all mothers, whether or not they come in saying, I need help or not, because they need to be anticipating potential problems that might be coming down the road and anticipating questions that would be there. And so we need to have a minimum of 6 contacts. When we look at the evidence at how effective this is, we find there are many studies that have been done on counseling and education. We're looking at just at the outcomes relative to exclusive breastfeeding. We see a 58% increase in the exclusive breastfeeding rates among those that were based in home and family settings. A similar finding for group counseling and healthcare settings as well. 38 studies here just in the home and family setting. So a significant amount of evidence saying that this really does work, increasing breastfeeding rates by 58%. Next slide, please. When we look at kind of a subset of these studies in other systematic reviews, focusing only on peer counseling and mother-to-mother support, so not necessarily the professional skilled support that's coming through the healthcare system, but by setting up systems in communities that mothers can support one another, we also find a significant protection against stopping breastfeeding in low and middle income countries, as well as in high income countries. And in fact, this community-based peer support could double exclusive breastfeeding at 3 months and triple it at 3 months in low and middle income countries. So numerous systematic reviews have looked at this evidence in different ways, but all of them coming to find a real protection against not breastfeeding. Next slide, please. Moving on to the 10 steps to successful breastfeeding. These have been recommended steps since 1989, a joint statement by WHO and UNICEF on how we can support breastfeeding in our maternity facilities. In 2018, WHO and UNICEF revised its guidance around the Baby-Friendly Hospital Initiative that really tried to move toward universal coverage, whereas the initiative had been focused on supporting those facilities or or designating facilities that were doing those 10 steps and doing them well, we really tried to move toward a much more public health-based approach, saying, no, every baby deserves appropriate care. And so we really need to change this to becoming the standard of care for all facilities, making sure that we're providing the systems support across the entire country. Looking at the evidence behind this, overall, we find a 45% increase in exclusive breastfeeding rates in those facilities that are adhering to these 10 steps. A dose response effect for the more and more steps that they actually do implement. Well, of course, we want to be implementing all 10 of them, and that is what we call for in every facility. We do recognize that there is an increasing effect with the more steps that we adhere to. And these effects are particularly strong in low and middle income countries. The evidence is even stronger there that this is really going to make a difference in supporting breastfeeding. Next slide, please. We look at national mass media prevention. This also was called for in the Global Strategy on Infant and Young Child Feeding, looking that we need to have social mobilization activities, including mass media, going for this. The evidence behind this is actually weaker. It's not as strong effects as providing direct support as we might expect. Mass media interventions don't change breastfeeding on their own, but we do find evidence that when they're integrated with counseling and community mobilization, it's associated with a 17% increase in exclusive breastfeeding rates. That's based on 5 studies that were done looking at mass media interventions here. It's not one of the key priorities for the Global Breastfeeding Collective because it is a weaker effect, but we do know that many countries do include this as part of their overall promotion of breastfeeding campaigns, and so we want to make sure we're looking at the investment cases for that. They do tend to be a little bit cheaper than the direct support that we're providing, but also a weaker effect here, but they are effective. Next slide, please. The International Code of Marketing of Breast Milk Substitutes also has important impacts on supporting breastfeeding. This has been called for by the World Health Assembly since 1981, when the Code of Marketing of Breast Milk Substitutes was adopted by the World Health Assembly. It has been reiterated 21 times by the World Health Assembly that calls on countries to implement the code, clarify certain provisions within it, and make sure that we're doing better monitoring and enforcement of that code. It remains a high priority for the World Health Assembly and for WHO and UNICEF. In a recent report that WHO published along with UNICEF and IBFAN, we found significant differences in the national rates of breastfeeding in those countries that have actually implemented the code. We have a dose response look at how strong their code is, if there's no code at all, if it has some of the provisions, or that it's substantially aligned where it essentially has all of the provisions of the code implemented. And you can see for exclusive breastfeeding there that it increases the rate of breastfeeding in the countries from 24% to 54%. So significant changes in exclusive breastfeeding as well as on continued breastfeeding, particularly at 1 year. The stronger the code that we have, the higher the rates of breastfeeding in the country. Next slide, please. And then we move on to paid maternity leave. As a key intervention, ILO has recommended fully paid leave for a minimum of 18 weeks for a number of years. The Global Breastfeeding Collective essentially echoes this, but actually asks for an even longer duration of paid maternity leave to go out to 6 months to correspond with the duration of exclusive breastfeeding, so the mothers really can stay with their babies throughout that entire 6 months, and even longer if possible, so that we can continue to support the mothers staying with their babies. We know that women are less likely to take the leave if it's not paid, and so just having policies that they are allowed to have leave is not adequate. We know that from the studies, less than 6 weeks of leave increases the odds of not breastfeeding fourfold. Those are studies in high-income countries that really demonstrate even those short durations of breastfeeding it is critical to have paid maternity leave offered to them. Overall, maternity leave is associated with a 52% increase in exclusive breastfeeding. Now, this is an intervention that is more expensive. Paying mothers' salaries for that time window, of course, it does cost the overall environment, the overall economy to a greater extent. But we have to recognize that the benefits of maternity leave are not only for breastfeeding. They have many other benefits for the development of the child and the bonding and family support going more broadly there. Next slide, please. And then finally, workplace breastfeeding support when the mothers actually do come back to work. They need to have access to quality childcare, breastfeeding breaks, and dedicated nursing spaces available to them so that they can continue breastfeeding when they do have to return to the workplace. ILO recommends at least one break during the day so that they can continue to either express milk or breastfeed their babies directly, as well as provide facilities directly for nursing or expression of milk. So this is built into our agreements among countries in these recommendations and conventions. The provision of workplace breastfeeding support and policies is associated with an 8% increase, according to the systematic reviews that were published a few years ago. It's not a huge impact, but it is the right kind of support that we need to be providing mothers, just so that they can continue to breastfeed once they've gone back to work. Next slide, please. Just want to finalize with just a few comments about this evidence, how we can strengthen it in terms of the ways we provide it. Mass media campaigns on their own probably are not particularly effective, but when they are coupled with counseling and community mobilization, they would have better impact. And so this needs to be part of a comprehensive support for breastfeeding. The adoption of the WHO code is, of course, important as a legal measure, but it has to be enforced as well. There's not a lot of value in just passing a law and saying, oh, companies ought to adhere to this, but we actually have to be catching the violations and making clear that we are enforcing those laws. In terms of the support within hospital and maternity centers, even small changes such as the ways that we provide support to them as they leave and their discharge, providing samples in those samples of formula in the discharge packs, that alone has been demonstrated to be a problem for exclusive breastfeeding. And so the simple kinds of changes that we can make in our policies in these facilities to make sure that we're supporting breastfeeding and not formula feeding are critically important. And finally, across all of these interventions, we know that monitoring the implementation of these drives accountability and sustained impact. We can't just say we're going to do these interventions, put the money into them, but we actually have to also invest in monitoring systems to make sure that we're holding ourselves accountable, finding where they're working, where they're not working, how to improve them, really take a quality improvement approach because of that monitoring. Next slide, please. Just want to thank you very much for your attention today. We're going to be using this body of evidence around what actually works to really drive the investment case. And so we'll turn it on to that. That is the next step. Back to you, Nina. Thank you.
Thank you very much, Larry, for that grounding in the evidence. It's always good to see what the evidence tells us, and it's always, I don't know whether it fascinates me or it discourages me that the evidence seems to have been saying much the same thing for all of the 20 or 30 years that I have been working in this field, and I'm sure it's been the same for many of you who've been working in the field for longer than I have. So with that, I'm now pleased to welcome Dr. Dylan Walters, who is the Senior Global Portfolio Director at Nutrition International, and he will present for us the updated global investment case for breastfeeding. Dylan is a health economist who completed his PhD in health economics at the University of Toronto and has previously worked with the World Bank, Alive and Thrive, and the Sick Kids Centre for Global Child Health. His team at Nutrition International leads the applied health economic research and modelling behind today's findings. His full biography, which is much too long for me to read here, is available in the chat. Over to you, Dylan.
Thank you, Nina, for the introduction. I'm honored to be here today for this World Breastfeeding Week event to present the findings of the new global investment case for improved breastfeeding. This investment case was a joint effort by my team at Nutrition International, led by Michael Ona, Samin Hassan, and Sakshi Jain, in collaboration with Larry Grummer-Strawn at the WHO and Fatmata Fatima Sise at UNICEF. Next slide, please. The main objective of this investment case for improved breastfeeding was to provide new data for policymakers and advocates on the questions of why invest in breastfeeding and how to invest in breastfeeding given scarce resources. And where possible, we hope to generate new data for advocacy for policymakers and decision makers around the world. Next slide, please. Next slide. Our analytical approach for this investment case analysis included, firstly, a rapid review of literature, looking at potential interventions, their effect sizes, and unit costs. Then we use this opportunity to update the data set for the Cost of Not Breastfeeding tool to provide new estimates on the health, human capital, and economic consequences of not breastfeeding for this launch event. For the investment case analysis, we then developed several combinations of intervention packages, which Larry has kindly outlined, plus scenarios for coverage and outcome targets for the purposes of comparison. With an analytical model based on the Cost of Not Breastfeeding tool, we conducted impact and cost modeling, plus a cost-benefit analysis. Next slide, please. For this analysis, we used a country sample of 88 countries with exclusive breastfeeding rates below 50%, plus a few countries with the highest numbers of non-EBF children. The analysis included standard assumptions on historical trends, population growth, inflation, and discount rates. We estimated the cost, impact, and economic returns of scaling intervention packages to 75% coverage in the primary analysis, and also a full coverage of 95% in the sensitivity analysis. Next slide, please. As Larry outlined, based on the literature review, a set of evidence-based interventions for the protection, support, and promotion of breastfeeding were selected for inclusion in the 3 investment case packages. These packages included a health system support package with breastfeeding counseling and education and the baby-friendly hospital initiative. A second package for policy and behavior change communications, which included provisions for national and mass media breastfeeding promotion campaign, and establishing and enforcing the International Code of Marketing of breast milk substitutes. And thirdly, the full system support package, which included all of the above interventions, plus provisions for paid maternity leave benefits and workplace breastfeeding support and policies for women working in the formal sector. These interventions support mothers and their children at various stages across the life course, pregnancy through birth, postpartum periods to infancy and early childhood, and when women return to work. The impact model we used included effect sizes from the literature for 5 out of 6 interventions, all except the international code, even though, as Larry mentioned, it presents strong indications of an effect of national policy alignment on improving breastfeeding rates. Next slide, please. Moving on to the findings. We first present the updated Cost of Not Breastfeeding tool results based on the most recent data available to the end of 2025. Globally, we estimate that each year, suboptimal breastfeeding costs approximately $339 billion in economic losses globally. This is equivalent to approximately 0.32% of global income. This is a substantial income penalty due to not breastfeeding globally. Furthermore, we estimate conservatively that we incur over $1.8 billion in health system costs as a result of not breastfeeding. Furthermore, not breastfeeding has a tremendous impact on the cognitive development of children, which is estimated to result in over 167 million IQ points lost in our children, and it is associated with not breastfeeding is associated with over 383,000 child deaths and 137 maternal deaths each year as well. Results of the cost of not breastfeeding for most countries, individual countries, are available in the updated NI and Alive and Thrive Cost of Not Breastfeeding tool. Next slide, please. Of course, There is wide variation in the cost of not breastfeeding by region, given the drivers of such as breastfeeding prevalence, under 5 mortality rates, income, and others. By region, most notably, the health consequences are highest in Sub-Saharan Africa, South Asia, and the East Asia and Pacific regions. The highest economic costs relative to income are highest in Sub-Saharan Africa, South Asia, and Latin America and the Caribbean regions. Next slide, please. With respect to the financing needs, and next slide, please. With respect to the financing needs of the investment packages, we estimate that the cost to scale up these interventions, we estimated the cost to scale up these interventions to 75% coverage. Scaling up the core health system support package with breastfeeding counseling and education and BFHI would cost approximately $4.6 billion globally over 10 years, or on a per child basis, less than $5 per child. Scaling the additional policy and BCC interventions as part of the second package would cost a total of $6.3 billion over 10 years, or just over $6 per child. Whereas the third package, the full system support package that includes maternity leave benefits and workplace support and policies, would cost approximately $13.3 billion in this sample of countries over 10 years. And on a per child basis, this comes to about $14 per child. We see in the charts on this slide that the highest cost interventions in terms of absolute cost are the workplace support and policies, though this could potentially be borne in part by a private sector or those employers, as well as paid maternity leave benefits and BFHI. Next slide, please. While that level of investment is indeed significant, the impact of scaling these breastfeeding packages would be very substantial. We estimate, based on our modeling, that this investment would result in between a 15 to 18 percentage point increase in global exclusive breastfeeding rates within 5 years by 2030, with the Core Plus and full system support package enabling the World Health Assembly target of 60% exclusive breastfeeding to be reached by 2030. Further scaling of these packages to 75% coverage of each intervention by 2035 would see those targets being exceeded and reaching 70% exclusive breastfeeding rates potentially by all of the 3 packages. Next slide, please. Globally, this level of investment and the resulting improvement in breastfeeding rates would lead to between an estimated 224,000 and 263,000 child deaths averted within 10 years. Each of these 3 packages is also projected to avert approximately 160,000 maternal deaths over the 10-year period. These investments demonstrate massive potential to improve child survival, and yet there is even more impact that can be achieved with more ambitious targets, coverage, and investment levels. Next slide, please. This major improvement in breastfeeding rates would lead to significant human capital gains through improved cognitive development by averting up to 133 million lost years of education and up to 382 million lost IQ points in children as well. The full system support package can achieve around a 17 to 24% incremental boost in human capital indicators compared to the core package. Higher investment means greater returns for human capital in our children. Next slide, please. While the health system support package cost is the lowest on the left-hand side in this slide, and it is the most cost-effective, it reaches a smaller population in need. The Core Plus policy and behavior change communication package is slightly more expensive with similar benefits for each dollar invested, but will have a larger policy and behavior change communications reach. The full system support package is the most costly and comprehensive. In terms of economic benefits, we estimate that these three packages of breastfeeding interventions, if scaled to 75% coverage of each intervention, can support the world to reach levels of exclusive breastfeeding between 70 and 73%, which can generate substantial economic gains between $276 and $357 billion in global economic gains over 10 years. The cost-benefit analysis suggests that each package demonstrates benefit-cost ratios of ranging between 27:1 and up to 59:1, which represents excellent return on investment and very good value for money. Next slide, please. Next slide, please. For policymakers, donors, and advocates, this investment case suggests that prioritizing breastfeeding interventions in maternal and newborn child health and nutrition plans, policies, and budgets makes sense because they are good value for money and can yield substantial health outcomes for families. Country-level economic analysis on breastfeeding investments is important for developing realistic plans and attracting investment as well. We also recommend developing government-led nutrition financing strategies to increase resource mobilization for breastfeeding interventions from a mix of domestic, public finance, development finance, and philanthropic financing sources for long-term sustainability. Lastly, utilizing Cost of Not Breastfeeding and investment case data at the global level and national level has shown to be effective for advocacy at all levels. Next slide, please. In summary, scaling the coverage of the core policy and Core Plus policy and BCC package, which included breastfeeding, counseling, education, BFHI, the International Code, and national mass media campaigns to 75% is ideal for meeting the World Health Assembly target of 60% exclusive breastfeeding by 2030. Further scaling coverage of all packages to 75% coverage by 2035 will allow for the achievement of greater than 70% exclusive breastfeeding rate, which will produce significant health and human capital benefits around the world. The projected benefit cost ratios continue to suggest that investing in the protection, support, and promotion of breastfeeding is excellent value for money with high and positive return on investment. Please see the full global investment case for breastfeeding report for details and visit the Nutrition International website to access the updated Cost of Not Breastfeeding tool. Next slide, please. I want to thank my colleagues across NI's health economics, communications, and advocacy teams for their dedication to this project. And of course, to collaborators at the World Health Organization, UNICEF, and Global Breastfeeding Collective for their technical and financial support for this analysis, as well as Global Affairs Canada for its financial support of Nutrition International. Thank you all for your attention today, and feel free to contact me for any questions or feedback. Back to you, Nina. Thank you.
Thank you so much, Dylan, for that comprehensive look at the numbers behind the investment case and the methodology. Next, we'll turn to the donor perspective and please welcome Dr. Olusulu Sotunda, who's the Senior Food Systems and Nutrition Advisor at Global Affairs Canada, who's joining us in a pre-recorded message. Dr. Sotunda leads strategic initiatives at the intersection of nutrition, health, food systems and gender equality, with more than 2 decades of experience in health systems and international development. His full biography is also available in the chat.
Excellencies, distinguished colleagues, partners, and friends, thank you to the Global Breastfeeding Collective, the World Health Organization, UNICEF, Nutrition International, and all the researchers and experts whose work has made today's discussion possible. Through Canada's support to Nutrition International, we are pleased to have contributed to this important new investment case and to efforts that strengthen the evidence base on maternal and child health and nutrition. It is a privilege to join you during World Breastfeeding Week as we examine one of the most significant and impactful interventions for improving health and well-being around the world. At its core, today's discussion is about people, ensuring every child has the best possible start in life. Every mother receives the support she needs, and in doing so, strengthening the foundations for healthier and more resilient communities. The evidence presented today highlights the wide-ranging benefits associated with breastfeeding. Breastfeeding improves child survival, nutrition, cognitive development, educational outcomes, and lifelong health, while also improving maternal health by reducing the risks of certain cancers and other non-communicable diseases. Its benefits extend beyond individual health. They can contribute to stronger learning outcomes, greater productivity, higher lifetime earnings, and more resilient economies. That is why the findings presented today are so important. The updated investment case contributes important evidence on the potential health, social, and economic benefits associated with breastfeeding. It provides useful analysis for governments, development practitioners, researchers, and financing partners seeking to better understand the relationship between nutrition investments and broader development outcomes. The report also highlights the significant consequences associated with inadequate breastfeeding practices. Globally, inadequate breastfeeding is linked to substantial health and economic costs, including preventable child and maternal deaths, increased illness, higher healthcare expenditures, and lost human potential. The discussion today also draws attention to a range of factors that researchers associated with improved breastfeeding outcomes, including access to skilled counseling, supportive health services, maternity protection measures, workplace supports, stronger links between health services and communities, and broader enabling environments for women and families. We also know that progress is possible. Recent data from the Global Breastfeeding Collective indicates that 16 countries have achieved meaningful improvements in exclusive breastfeeding rates. These experiences provide valuable insights into the policies, programs, and partnerships that can support progress in different contexts. This approach aligns closely with Canada's international development objectives. Canada remains committed to evidence-informed programming that supports country-led approaches, advances health and rights of women, children, and adolescents, improves nutrition, and contributes to sustainable development outcomes. We are meeting at a moment of considerable global complexity. Around the world, the need for assistance is rising as conflicts become longer and harder to resolve. Climate change continues to affect communities and livelihoods. At the same time, development resources face growing pressures in Canada and around the world. In this environment, evidence matters more than ever. Health and prosperity cannot be achieved by any one country or institution acting alone. Progress depends on partnerships that bring together governments, multilateral organizations, civil society, researchers, communities, and development partners, each contributing their expertise and strength. Canada welcomes the findings presented today and values the contribution they make to the global evidence base on maternal and child health and nutrition. We look forward to continued dialogue and collaboration with partners as we work together to support healthier futures for women, children, and families around the world. In closing, I would like to thank World Health Organization, UNICEF, Nutrition International, the Global Breastfeeding Collectives, and all those who contributed to this important work. The evidence presented today deepens our collective understanding of the health, social, and economic benefits associated with breastfeeding and provides an important contribution to ongoing policy and program discussions. Together, through collaboration, partnership, and evidence-informed approaches, we can continue advancing better health and nutrition outcomes for women, children, and families around the world. Thank you.
Thank you, Dr. Satunda, for that perspective from the donor community. We now turn to we now turn to our country-level panelists for their perspectives on what this investment case means on the ground. Joining us today are Ms. Veronica Kirogo from Kenya, Dr. Shabina Raza from Pakistan, and Ms. Nima Mwapili from Tanzania. I can't tell you how many times I practiced that, Nima. Sorry about that. Ms. Veronica Kirogo is the head of the Division of Nutrition and Dietetics at Kenya's Ministry of Health. Dr. Shabina Raza is Nutrition International's Country Director for Pakistan, and Ms. Nima Yoshua Mwapili is Assistant Director for Nutrition Services at Tanzania's Ministry of Health. She has more than 20 years of experience in nutrition policy program and multi-sectoral coordination. Full biographies for each panellist are available in the chat. We're going into an open... We are, as you know, the Q&A function is open, so please continue to submit your questions, and if we have time, we'll address them after we've heard from the country panellists. If you don't get your question, if we don't get to your question, the panellists will try to answer them directly in the Q&A, but unfortunately, we don't usually get to everybody's question. I hope you'll understand. Now let's hear directly from the countries, and we'll begin with our first round of questions. So Ms. Veronica, Dr. Raza and Ms. Nima, if you could turn your cameras on so we can have a conversation. And I'll ask, what investment, Ms. Veronica, in Kenya has stood out as improving breastfeeding outcomes?
Thank you very much, Nina. Kenya experience demonstrates that sustained investment in breastfeeding delivers measurable results. According to the 2022 Kenya Demographic and Health Survey, 60% of infants under 6 months are exclusively breastfed, exceeding the World Health Assembly target of 50%. We have also maintained 60% of early initiation of breastfeeding. These gains reflect long-term investment in 4 key areas. 1, we have invested in enabling policy and regulatory environment. Kenya Constitution recognizes every child's right to basic nutrition, and this has been translated into policies and legislation, including Breast Milk Substitute Act, the Health Act, the Employment Act, Kenya Nutrition Action Plan, National Maternal, Infant and Young Child Strategy, and they have created strong foundation for protection, promoting and supporting breastfeeding. The second one, we have integrated breastfeeding into the health system rather than treating it as a standalone program. Breastfeeding counseling is part of antenatal care, maternity services, postnatal care, and primary health care, including community health strategy. We are implementing the baby-friendly hospital initiative, the baby-friendly community initiative, maternal, infant, and young child nutrition in emergencies, and also supporting vulnerable mothers and infants during emergency. We have institutionalized a monitoring of breastfeeding indicators through the Kenya Health Information System and periodically through the Kenya Demographic Health and Survey. And this has enabled evidence-based decision-making. We have also invested in people. We have strengthened the capacity of healthcare workers, and we are leveraging 107,000 community health promoters, together with mother-to-mother support group, to provide counseling and support breastfeeding to mothers. Finally, we have embraced innovation. We are piloting human milk banking so that we ensure newborns who are vulnerable have access to safe donor human milk when clinically indicated, but while enforcing the mother's own milk remain the first choice of nutrition. Thank you.
Thank you so much, Dr. Ms. Veronica. I'd like to turn to Dr. Raza to ask her the same question. What investment in Pakistan has helped improve breastfeeding outcomes there?
Yeah, thank you. Let me also share here that besides being a doctor, I'm a working mother with 3 kids who I breastfed 2 years each, in spite of the challenges that working women have here in Pakistan. But I would always say that where there's a will, there's a way. So my journey of more than 30 years of being associated with supporting, protecting, and promoting breastfeeding is still on. And I'm very happy to see that over the years, as more investment and attention has gone into this important and critical public health intervention, we are seeing improvements in the related indicators. So in Pakistan, the government and the development partners, and I must be fair to the Pakistan Pediatric Association, whose efforts have and the investments into breastfeeding programs have strengthened healthcare providers' capacities. We've also set up counseling services, lactation management clinics, baby-friendly hospital initiatives have been implemented. Also, maternity protection policies have been put in place. In 2023, at the federal government, the maternity leave has increased from 3 months to 6 months for working women. And similarly, we've had some very good program under the social protection platforms. And all of these together have helped improve the breastfeeding indicators. For example, exclusive breastfeeding. If I look at the national data, then in 2013, it was 38%. And in the next 5 years, it grew up to 48%. So this progress was actually, we see it as a combined effort. We cannot call it a full success yet, because if I look at other indicators like early initiation and equitable access to support for these mothers, that there's still a big gap there and much needs to be done. But in Pakistan's experience, investment works best when we are addressing the policy, also the services and the community support together. So put together, we've definitely seen improvement in indicators. Thank you.
Thank you so much, Dr. Raza. And Ms. Nima, would you like to share how investment in breastfeeding has improved the breastfeeding situation in Tanzania? Nima, I think you're still on mute. There you are.
Okay. Thank you very much, Nina, and the organizers of this World Breastfeeding Week webinar. In Tanzania, I believe you all know my name now and my position. I should not introduce again, right? Okay. Tanzania recognizes breastfeeding as a core child survival and nutrition intervention. So breastfeeding is integrated in national nutrition plans, reproductive and child health plans, strategies, and the policies. Thus, breastfeeding is not implemented as a standalone program or project. The government in Tanzania collaborates with the health and nutrition partners puts much effort to support and protect and promote breastfeeding. Breastfeeding is also integrated in the National Multisectoral Early Childhood Development Program, and it is part of the primary health service delivery. Breastfeeding is supported across all sectors through the National Multisectoral Nutrition Action Plan, which brings different sectors together for nutrition improvement in the country. So it might be a bit difficult to single out the specific financial investment in breastfeeding because it is embedded in various health and nutrition interventions, and the effort and these investments have really shown improvement in breastfeeding indicator. For example, the exclusive breastfeeding is increasing. We can see an improvement from the 2010, where we had 53%, to 2015, where we had also 59%, and now 2022 data show at the exclusive breastfeeding 64%. Also, the early initiation is also increasing from 49% in 2010, and then 51 in 2025, in 2015, and now we are at 70% as per 2022 data. So we believe what we do is helping to improve the breastfeeding outcomes and the indicators in the country. Just to mention few, what has been done in nutshell, the government has been setting an average of Tanzanian shilling 1,500, approximately 0.2 in the country. This fund is mainly used to implement nutrition intervention within the health sector, and breastfeeding is one of the intervention that is supported by this finance from the government. Specifically, the intervention that are supported by this investment done by the government include breastfeeding promotion, breastfeeding
Oh dear, I think Ms. Nima's connection has been lost. I'm so sorry about that. While we wait for her to reconnect, let's move to the next question. So Ms. Veronica, what barriers have underinvestment created to progress in breastfeeding in Kenya?
Thank you, Nina. While Kenya has made significant progress, several challenges remain, and these also provide very important lessons. First, breastfeeding programs continue to compete with many other health priorities for the limited resources. This can affect investment in health worker capacity, breastfeeding counseling, community support, regulatory enforcement, and monitoring system. In response, the ministry is strengthening integration of breastfeeding within the primary health care so that it remains part of routine service delivery. Second, although from the Kenya Demographic and Health Survey, 89% of births are attended by skilled health personnel, only 60% of the newborns are breastfed within first hour of birth. This tells us that expanding access of skilled delivery alone is not enough. We must also invest in quality of care provided immediately after birth. Kenya is therefore strengthening the baby-friendly hospital initiative, enhancing mentorship for healthcare workers, and reinforcing breastfeeding counseling before mothers leave maternity facility. Third, changing social and economic realities present new challenges. Increasing urbanization, mothers returning to work, aggressive and evolving marketing of breast milk substitutes, including through digital platform, influencers, and misinformation in maternity protection, workplace breastfeeding support, public education, and regulatory enforcement. Fourth, because health service delivery in Kenya is devolved, sustained progress depends on continued investment and ownership across all the 47 county governments. The national government provides policy leadership, standards, and technical guidance, while counties are responsible for implementing services. Therefore, continued collaboration between the two levels of government is therefore essential. Our experience has taught us that breastfeeding requires continuous investment. As new challenges emerge, our response must also evolve. The solution is not less investment, it is smarter and more sustainable investment in health system, communities, and mothers. Thank you.
Thank you so much, Ms. Veronica. And Dr. Raza, thank you. I'm glad you're back. Would you just give us a very short summary of what barriers underinvestment has created for making breastfeeding progress in Pakistan?
Yeah, thank you, Nina. So just like Veronica said, similar problems, issues in all of our countries. But I just like to highlight that, breastfeeding is often considered as an awareness issue for this mother who is supposed to be the sole responsible to ensure that breastfeeding is well established. But we know in reality, if you want breastfeeding to work well, then she needs that skilled support around her. And with, say in Pakistan, there's a major shift now from extended families to having more nuclear family structures. And that's where these young mothers do not get the required support, continued support. I can give an example from my own daughter-in-laws. When, literally, they were not ready to breastfeed if it wasn't for me to have actually support them through those early days and encourage them. And now they're grateful to me. They said, thank God we're breastfeeding, because the hassles of bottle feeding and also the issues when the child goes unwell and is, sick, and they realize how the baby latches very quickly on. It's so convenient to continue breastfeeding. So that kind of support is still much needed, that support system for this. But unfortunately, because of lack of, investment overall across the country, I won't go into details, but Veronica explained very well how, at the sub-district level and different levels that we have within governments and health services provision, it's similar to all. But one thing I'd like to also highlight is that, like, Pakistan has laws which regulate the marketing of breast milk substitutes, but then we are not effective in implementing because we don't have dedicated budgets to ensure that the monitoring system and accountability is well placed. And so there's aggressive marketing and misinformation in which, fills that gap where the trusted breastfeeding support should have been consistently present. Another important development in Pakistan I see is that the workplace support is much needed now. It's becoming increasingly important because in Pakistan, the female labor force has increased substantially over the last 5 years. And what we see, especially in the informal sector where most of these women are working, they do not have the adequate maternity leave or the nursing breaks and health breastfeeding facilities. So that is attributed partly to lack of investments there. And so the consequences of underinvestment are substantial. Like we heard Dylan say, the cost of not breastfeeding. So in Pakistan, inadequate breastfeeding is associated with 34,000 preventable maternal and child deaths. And a loss of $2.8 billion per annum to the economy. So if you look at the investment, the underinvestment, it transfers into much greater costs to the families, to the health systems, and to the nation as a whole. So yeah, thank you.
Thank you, Dr. Raza. I think many countries struggle with underinvestment in health professional education and skills, and also in enforcement of the code and other policies, and those create significant barriers to progress. Dr. Nima, are you still with us? I think she may be having a connection issue. So let us move on very quickly to our third question, which is what advice would you give for engaging donors and decision makers in your country? Now, we're running a little bit short of time. So if you can distill your answer down to two sentences, we would be most grateful, because that will give us time to answer some of our delegates, our attendees' questions. So let's start with with Ms. Veronica, and then we'll return to Dr. Shabina.
Thank you, Nina. And I think this question is very timely after Dylan presented the economic case for breastfeeding. So my first piece of advice is we need to change the conversation from cost to investment. When $1 is generating $59, I think no smarter investment is like that for breastfeeding. In fact, for Kenya, because we also had done a cost of investment for high impact nutrition intervention, where $1 invested generates $22. I think now with the recent finding now, it gives us, really a very solid case for why countries should invest in breastfeeding. I think also for Kenya, we already know that child nutrition cost the economy 373 billion Kenya shilling, which is about 4.3 billion USD. And therefore, it means that we need to scale up this investment, and we require the donor support. And I also want to share that, Kenya as a country, we were recently recognized as a World Bank Human Capital Champion, because one of the things we have been able to reduce is stunting from 35% in 2008 to 18% in 2022. And what that means, even with the new targets for breastfeeding, it is possible when donors join hands with the government and partners. Thank you very much.
Thank you so much for the longest two sentences that even an Australian has been able to give us. So I'm going to give you the award. Dr. Azad, do you think you can find those short sentences for us so that the panelists can answer our delegates' questions?
Right. So I'll just say, to add on, one, I think we should link breastfeeding to the donors' priorities like child survival, stunting reduction, maternal health. And present it so. And the number two, I think what works very well with donors is to share successful examples where you can demonstrate measurable reach and impact. And from my own little life's example, where I've relactated more than 1,000 mothers, and I've helped my hospital become a baby-friendly status, and attracted UNICEF to give us funding to replicate baby-friendly hospitals throughout our province. So I think it really works well. Thank you.
Thank you so much. I think both of those stories tell us that we need to make sure that we collect good data when we do invest in breastfeeding, in interventions to support breastfeeding, so that over time we can demonstrate success, and we can link our successes to the kinds of outcomes that are important to donors. And we know that breastfeeding interventions are double duty actions. So not only do they prevent wasting, but they also prevent non-communicable disease by preventing overweight and obesity. So I'd like to, what I'd like to happen now is, could all of the panelists please turn their camera on? Thank you very much to our country panelists from Kenya, Pakistan and Tanzania. If we can have Dylan and Fatmata and Larry all with their camera on, so that we can turn to answering some of your questions online. Let me just quickly open up the Q&A again. It was decidedly distracting there for a minute. So could we maybe start with a question about the cost? If the cost benefit has been known for so long of these interventions, what holds countries and their systems back from adopting what so clearly what we know so well works? And just raise your hand. Who would like to answer this question? I'm going to open it up to everyone because it's one of those questions. Amir, would you like to answer that question for us?
Thank you very much, colleagues. And again, happy World Breastfeeding Week, and indeed a great presentations, panels, and the great questions. Actually, I was enjoying going through. So I have just a few reflections on that. And that question, I think, came across a number of times, that why we know all these investment benefits and etc., why it's not happening. I think there are a few things we have to be cognizant, and then knowing those, perhaps we can navigate better our policy advocacy and programming in the country. One is that often these benefits are having relatively a long-term visibility. Often that does not really match with the political plans and budget cycles and etc. Sometimes the cabinets, they want to showcase and the impact areas that is more visibly and shorter term. I think this is something that definitely requires the health policymakers and us and the colleagues on the ground in the countries to basically be cognizant of that. The other thing is that a lot of the proven interventions that they were presented, they are beyond only one health, beyond one sector. It's not only Ministry of Health. It should be Ministry of Labor, Social Protection, Finance, and etc. And when we all know, when it comes to multi-sectorality, it requires more investments and more time and coordination and perhaps political will on that. And then often by default, breastfeeding, I mean, that's also, you can often hear it even from high officials and even ministers, that they see as a pure responsibility of the mothers. They think it's a no-cost intervention. It should be a responsibility of the mother to breastfeed, without really recognizing the fact that all these network of support and services is required, policies, regulations for mothers to be enabled to do the breastfeeding. There are so many other factors. I just don't want to go on many of them, but the whole issue is that definitely we recognize that the implementation capacities are uneven. There are countries that they may adopt policies but lack trained workers, or may lack reinforcement of the regulations and policies. This could be another reason. And lastly, breastfeeding is often politically invisible. And I think that is one of the reasons that this great new publication and the wealth of evidence and the policy brief is going to help all of us on the ground in the countries to be able to move the needle a little bit and make this invisible, very cost-effective intervention and life-saving intervention more visible. Over back to you.
Thank you so much, Amir. We're very short on time, but is there someone who would like to add like one more sentence? Amir's answer was very comprehensive. Unfortunately, I think we don't actually have time for any more questions. So let's leave it there, and I'm sure that you can continue to answer the questions in the Q&A panel. Thank you so much, everyone. So as we close today's webinar, I would like to extend, please feel free to turn your cameras off again, panelists, and we'll close the webinar. And as we close, I'd like to extend particular thanks to Nutrition International for the extraordinary support they've provided for this year's World Breastfeeding webinar. As well as developing the investment case, they also coordinated collection and editing of the Voices of Mothers video, created infographics, and helped us, did the lion's share of the webinar planning. So thank you very much, Dylan, to you and your team. Behind the scenes, I would like to thank Jürgen Jonsson for managing the Zoom platform, Kelly Hilberger for managing slides, and Jeanette McCulloch for managing all of us. Thank you also to Mariana Colmenares for managing Q&A and the chat. So let us conclude our time together today for World Breastfeeding Week 2026 by reiterating, the evidence is clear. We know what works. First, we must invest in the comprehensive package of package of interventions, including implementing and enforcing the code, implementing the baby-friendly hospital initiative, or the 10 steps to successful breastfeeding, and providing community and workplace support, including paid maternity leave and ongoing breastfeeding counselling provided by well-trained and skilled breastfeeding supporters. Second, we must close the financing gap through scaled domestic and international funding. We know that investing in breastfeeding returns $59 for every dollar that is invested. This is an incredibly lucrative investment, and there should be no reticence to countries for making these investments. And third, we should align new investment with the Global Breastfeeding Collective's call to action, which you can find at the link which has been provided in the chat. I want to thank you all for joining us today and offer my best wishes for the rest of your day or for the evening, and especially for the rest of World Breastfeeding Week. I hope to see you again next year.